Okay, dear professors, colleagues online, I'm Jian Wang, the editor-in-chief of JACC Asia. Welcome to JACC Asia series on TCTAP 2022. It is my great honor and a pleasure to meeting you online. On behalf of the organization committee, I would like to say thank you to all of you for your spending time with us from your busy schedule. As you know, JACC Asia is the only and the first regional specific journal of JACC family. It is built for serving all the authors, readers, researchers, and practitioners in Asia and beyond, leveraging the well-renowned platform of JACC. JACC Asia has kicked off with a great start. Since its inception in February 2021, we have received more than 370 manuscripts with an acceptance rate about 13 to 14%. This year, we have increased publication cadence from quarterly to bi-monthly. Our special issue, Pulmonary Hypertension, will be online very soon. And the notice for call for papers on racial disparities in cardiovascular diseases and anti-atherosclerotic target treatment will go live on JACC Journal's website soon. So we are more than happy to receive your submissions and publish your research on JACC Asia. The vision of JACC Asia is to shape the future of Asian cardiovascular community. To achieve this vision, we are committed to strengthening the nurturing of physician scientists and striving to provide education. That's why here today. So I wish today's webinar a fruitful session. Many thanks. Thank you all.
Okay. Thank you, Professor Jian Wang. Give us a very nice opening speech. And welcome everyone. Enjoy our new research 2022 in JACC Asia. This session is co-organized by JACC Asia and the TCTAP. And I'm Yundai Chen, and also from Beijing, and also is associate editor of the JACC Asia. And today we also moderator D.W. Park, also is associate editor and chair of this TCTAP. Thank you, you organized this eventful session. And tonight we also have three wonderful lectures, and also panelists Takashi Kubo and also Zhao Dong. Totally is associate editor of the JACC Asia, and Kubo from Japan, very famous interventional cardiology, and Zhao Dong also from Beijing, is Peking Engine Hospital. And other speakers, and one is from the South Korea, Dr. Professor Bangkong Ku, and another Yunpeng Zhu is from the China Beijing Hospital, Shanghai. And also we have my old friends, also Professor Yingxin Xin, Professor Xin, hi, is from the Wushan Medical Center, Korea, Republic of Korea. So I think we should have a wonderful night. And thank you. First of all, I want to introduce the first lecture, sex difference in plaque characteristics and myocardial mass, implication for physiological significance, from the Bangkong Ku. It's a video, right? Yeah, please.
Thank you for the kind introduction. Hi everyone, I'm BK Gu from Seoul National University Hospital. Today I would like to talk about the coronary physiology in women, or sex differences in coronary physiology in terms of myocardial mass and plaque characteristics. you're looking at two LAD stenosis, one in female, the other in male. To me, this lesion seems to be more significant. So if I have to say about the functional significance of the lesion, I should say this one should be the one. However, in previous studies show that even the same degree of percent diameter stenosis or stenosis severity, women tends to have a higher FFR or the less severe physiologic significance. And our group also presented the similar findings in defined flare study. Women has a higher FFR than men, despite similar anatomical severity. And it's interesting to see that there's no difference in resting indices. So this lesion, FFR is 0.85, so medical treatment was performed, but this lesion, less severe, but FFR was 0.76 in male patients and PCI was performed. However, we still don't know about the detailed mechanism and prognostic implication of these differences. So our study investigated sex differences in plaque characteristics and myocardial mass for the implication of physiologic significance. So this study was designed to evaluate the sex differences in plaque characteristics and myocardial mass and their implications in physiologic significance and clinical outcomes. So the study population was derived from FFR-CT registry, which was a combination of three-vessel FFR French study, which is international multi-center study, and institutional registry of Jujura Gyodo General Hospital. So in our study, 655 patients, around 1,200 vessels, women 166 patients, and men 489 patients. For these vessels, we did a very detailed collaborative CT analysis for LV mass and quantitative and qualitative plaque analysis with the invasive coronary physiology measurement and CEC adjudicated focal at 5 years in deferred vessels. So here you're looking at the baseline differences between men and women. As you can easily expect, women older, more hypertension and smaller vessels. But the percent diameter stenosis was similar, but FFR was higher and functional significant lesion was less frequent in women, which is similar to the previous presentations or publications. And now, when you see the CT characteristics, first you see that LV mass is smaller in women than in men, which is well-known difference. And vessel area at the MLA site was larger in men without the difference in MLA and plaque burden. When you see a three-dimensional whole vessel analysis, like the changes in LV, differences in LV mass, vessel length longer, vessel volume larger, plaque volume larger, lumen volume larger, but no differences mean plaque burden. However, it's interesting to note that the bad component, fiber fatty and necrotic core volume in terms of absolute value and percentage is larger in men than in women. So there's a difference in myocardial mass, vessel volume, and plaque characteristics. And this diagram illustrates the distribution of CT parameters between women and men. No difference in MLA, plaque burden at MLA site, mean plaque burden, but FFR is higher in women than in men, which illustrates the difference in physiology despite similar lumen narrowing and plaque burden at MLA site and as a mean plaque burden. So, as mentioned earlier, there was a difference in vessel volume, plaque volume, and lumen volume between men and women. And we want to see whether adjustment for LV mass can change this difference. And when these vessel plaque lumen volume was adjusted by LV mass, there was no difference between men and women, so that the difference in volume for the vessel plaque lumen can be explained by the difference in LV mass, and this cannot explain the difference in physiologic significance. It is interesting to see that there's a difference in plaque volume, and there's a tendency that the women has a higher percentage of dense calcification and less percentage in necrotic core and fibrofatty plaque, and also the fibrous plaque. And when we compare the differences in percent plaque burden area stenosis, there was no statistically significant difference, but bad component male has a significantly higher. Low attenuation plaque positive modeling was significantly higher in men, which shows that even though there was no difference in plaque burden and percent area stenosis, plaque component is worse in men than in women. And when you analyze the predictors for FFR, when only the sex was included in a model, it was a significant parameter. And even adjusted by LV mass and even adjusted by plaque volume and plaque components, sex was significant. However, when both LV mass and plaque volume and high-risk plaque characteristics was included in the model, sex was not a independent predictor for sex, which shows that the mass, plaque component, and volume can be a component to make changes in difference in physiology. And when we analyzed the outcomes in deferred vessels, there was no difference in women and men, but there was a difference in outcomes according to the functional significance and plaque characteristics. And when we also analyzed the independent determinants of 5-year vocal, diabetes, functional significance, pass remodeling, and high plaque burden were a predictor, but sex was not. So in summary and conclusion, ladies and gentlemen, higher FFR value for the same stenosis severity in women can be explained by a smaller myocardial mass and less frequent high-risk plaque characteristics than in men, but in deferred vessels, sex was not an independent predictor for clinical outcomes. Thank you very much for your kind attention.
Thank you, Professor Ku, wonderful lecture. So on the schedule, we can invite the panelists and other give us a discussion.
So I have one comment, also question to the Professor Gu, and I think Professor PK Gu study is very interesting, and on the basis of the previous data, we know in PCI patient, woman is usually underutilization. Also, PCI short and long-term outcome was poorer than men. So in bypass surgery, I also similar outcome was noticed in previous several studies. So at this study, it shows the plaque vulnerability much higher in men, but it's after adjustment of LV mass, and the most different characteristics was well explained by some LV max. There was some also explained the BMI, also PSA, something like that. So, and the Professor Gubo, and you have a very nice imaging analysis, and you also published a lot of paper to define the underlying mechanism, also baseline characteristics and between woman and man. Is what it is so in the is there and the vulnerability difference, and how do you define this? What is big difference of man and woman for predicting vulnerability of a HS event, also another event?
Thank you very much, Dr. Park. I believe it's a very important question and a beautiful comment. So, first of all, I would like to say congratulations to Dr. Ku. This is a very great study showing the higher FFR in women. the mechanism, it was previously unknown, but he proved it firstly in the JACC Asia publication. So I understand he demonstrated higher FFO is caused by a smaller LV mass in a smaller supply area. In addition, lower vulnerability in the carbonic plaques. So FFO is affected by those parameters. And especially we are interested in the plaque characteristics. If the lesion has a complex, including the plaque rupture, or think of fiber trauma, with the calcified nodules. If the same lumen area, but FFO decrease is quite different. So in those means, he demonstrated a woman has a lower FFO. It means lower plaque vulnerability. But this concept is considered in the intermediate lumen area lesions. If the lesion is very severe, the complex morphology is directly affected the future clinical acute coronary events. And so we have to take care the lesion is intermediate or significant. So in those cases, plaque characteristics might be more important to the clinical outcomes. I believe so. Thank you so much.
I think it's quite interesting. Also, I have a question for the Kubo. And don't you think because for the women in the same stenosis severity, but with a high FFR, I think the mechanism maybe this paper shows maybe it's a smaller myocardial mass. But don't you think for the female maybe have some microvascular dysfunction also can contribute to this issue? And also is quite have a very high rate of the associated with the clinical outcome. So yeah, don't you have some comments for this? And also the things also is another mechanism is less high risk plaque characteristics in women. I think only for the fibrotic plaque, fatty and plus necrotic core, don't you think is enough, or can get this kind of maybe need another OCT or other physiological testing can give more consideration for this?
Thank you so much. So I consider your comments is very, very important. So Dr. Ku demonstrated and investigated about the epicardial coronary artery physiology. And also microvascular dysfunction is very, very important predictor for future prognosis. So we consider both epicardial coronary artery disease and microvascular disease when we consider the future coronary events and prognosis. So as you say, the epicardial coronary artery blockage severity may be lower in women, but microvascular disease may be higher severe in women. So both is absolutely affect their future prognosis. So I consider CFR, another FFR, might be useful for predicting future event in our daily clinical practice. And also, if we predict the epicardial acute coronary events, imaging might be useful to evaluate the lesion morphologies, including think of fiber trauma or large lipid core, macrophages and infiltrations. So we consider both physiology and imaging is very important to predict future coronary events in patients with coronary artery disease. Thank you very much.
Thank you for your comments.
So I think we have enough discussion for first topic. So I'm gonna move to the second topic. This is the important sub-study is important trial about the bypass surgery. I'm gonna introduce Dr. Yoon Pen Ju, and he will speak and influence of baseline HbA1c and the antiplatelet therapy on 1 year vein graft outcome. And Professor Ju, can you present your study?
Thank the committee for the opportunity to present our research result. The influence of baseline HbA1c and antiplatelet therapy on 1 year vein graft outcome. This is a disclosure. Approximately 1/3 of patients with diabetes have coronary artery disease. The 2/3 deaths of them are attributed to the coronary artery disease. For patients with diabetes and complex coronary artery disease, the current guidelines made a preferred recommendation on CABG as a golden standard for myocardial revascularization. Although the arterial graft are the first choice, the vein grafts remains the most commonly used worldwide. However, the occlusion rate of vein graft is about 11% within 1 year and 40% to 50% at 10 years. HbA1c level represents the glucose control over the past 90 days preoperatively, and it can be used as a factor to evaluate glycemic control. Higher pre-op HbA1c level were associated with a higher cardiovascular risk and the late mortality after CABG. However, the effect of HbA1c on vein graft outcome is still unclear, especially in the early term. This post hoc subgroup analysis of the TCTAP trial is to assess the association between baseline HbA1c and 1 year vein graft patency after CABG, and the second, and the effects of ticagrelor with or without aspirin versus aspirin alone on 1 year vein graft patency after CABG in patients with baseline HbA1c less 6.5% versus over 6.5%. The TCTAP trial was a multiple center open label randomized trial that enrolled the patients undergoing elective CABG in China in 7 hospitals. For 500 patients were randomized 1:1 to receive different antiplatelet therapies within 24 hours after CABG and for till 1 year, which is ticagrelor 90 milligram twice a day plus aspirin 100 milligram per day, ticagrelor alone and aspirin alone. Of them, 405 patients with baseline HbA1c data available were grouped according to the low HbA1c, which is less than 6.5%, and the high HbA1c over 6.5% subgroups. The primary outcome was the graft patency assessed by CTA or CAG at 1 year after CABG. The patency rate was graded as a Fitzgibbon classification. Grade A, the graft is totally patent and the stenosis is less than 50%. Grade B stenosis is between 50% to 100%. Grade O, which is totally occluded. So the primary outcome was defined as patency Fitzgibbon grade A versus non-patency Fitzgibbon grade B plus O. According to the available baseline HbA1c data, there were 233 patients, 678 vein grafts in the low subgroup, and 172 patients, 512 vein grafts in the high subgroup. The baseline characteristics were generally comparable between two groups. At the graft level, the 1-year vein graft patency rate was 86.1% in the low subgroup and 77.9% in the high subgroup, respectively. Compared with the low subgroup, the high subgroup showed worse patency. The adjusted odds ratio was 1.69. The similar results were observed for vein graft patency occlusion or in the patient level analysis. The results remained consistent in the sensitivity analysis using HbA1c cutoff value 7.5%, 7.5%, or 8%. Furthermore, when analysis as a continuous variable, baseline HbA1c was associated with the vein graft failure. The adjusted odds ratio was 1.25. So the higher baseline HbA1c, the worse vein graft outcome. We also studied the impact of baseline HbA1c on arterial graft patency. The 1-year arterial graft patency were about 90% in both groups, variously higher than vein grafts. However, unlike the vein grafts, there was no difference in arterial graft outcomes between the baseline HbA1c subgroups. For the vein graft outcome among randomized different antiplatelet therapies in HbA1c subgroups, it was consistent with the general population in the TCTAP trial. Ticagrelor plus aspirin showed a higher patency rate compared with aspirin alone in both low and high HbA1c subgroups. Point estimate odds ratio was 0.34 and 0.45 respectively. There was no interaction effect between baseline HbA1c and antiplatelet treatments. There were no significant difference in patency for ticagrelor alone or versus aspirin alone in both low and high HbA1c subgroups. Point estimated odds ratio were 0.65 and 0.78 respectively. So we concluded that in the TCTAP trial, higher baseline HbA1c was associated with a lower vein graft patency 1 year after CABG. Ticagrelor plus aspirin dual antiplatelet therapies improved the 1-year vein graft patency versus aspirin, irrespective of baseline HbA1c level. Multiple arterial grafting should be promoted in patients with poor glycemic control. Thank you for the attention.
Okay, thank you. So as the editorial short commentary, I'm gonna introduce the world-renowned cardiac surgeon, Dr. Mario Gaudino, and he was a PI in the radial trial, the comparing radial artery versus saphenous vein in bypass surgery, published in New England Journal of Medicine 2018. And Mario will short commentary, and then we will have a short discussion. Okay, Mario.
Thank you very much, Dr. Park. I think this is an incredibly important analysis. I was privileged to be part of the review process, and I am grateful to the editors of JACC Asia for giving me the opportunity to help in the process. This is an incredibly important study for many reasons, and I will try briefly to summarize why this is so important. First of all, like Professor Zhao very nicely summarized, vein grafts are still the most common graft used in coronary artery bypass surgery. So studying vein graft, it's really, really important, because at the end of the day, this is what the average cardiac surgeon is using every day in the majority of the patient. That's why the contribution from Dr. Zhao group is very important. It's even more important because a very large number of patients undergoing bypass surgery have diabetes. In the United States, as you know, more than 40% of the patients that undergo bypass surgery have diabetes. So it's a very important clinical question. The glycemic control, we knew that was associated with all-cause mortality and cardiovascular mortality, but that may be related to the effect on diabetes, on the general atherosclerotic burden, not necessarily to graft occlusion. And we did not have mechanistic information on the effect or the association between glycemic control and graft occlusion. And these post-hoc analysis of the TCTAP trial clearly show us that there is a strong association between glycemic control and graft patency. Now, in cardiac surgery, I believe that the imaging study, patency study are very, very important, because when you are testing an intervention that can affect patency, you cannot rely only on clinical outcome, because clinical outcome are confounded by the natural history of the disease, for example. And so having that mechanistic information that Dr. Zhao has very nicely provided, I think it's really, really critical. I think now the question is, where do we go from here? Using multiple arterial grafting, like Dr. Zhao has suggested, would be in patients with diabetics and poor glycemic control. It's a good option. However, we must consider that the use of the bilateral internal thoracic artery in patients with poor glycemic control carry a very high risk of sternal wound complication. And sternal wound complications are associated with long-term mortality. So probably the use of bilateral internal thoracic artery in those patients is not ideal. And I would suggest that the radial artery, it's a much better option. And there are studies that show that the radial artery has the same patency rate in diabetic and non-diabetic. And the other important consideration is clearly medical therapy. And, you know, after ischemia, we all have to recognize that medical therapy is probably the winner. So better medical therapy, better glycemic control, it's also critical in those patients. And now I will be happy to be part of the discussion, but I want again to thank you all for the privilege of being part of the meeting, and Dr. Zhao, who is a personal friend, for this for another outstanding contribution.
Okay, great.
Thank you very much, Mario.
So I think I propose the pragmatic, practical question, and Mario, you are reading in the lot of clinical trial in bypass surgery part. So my practical question: what is the current standard for antiplatelet therapy after surgery? In the TCTAP trial published, I remember JAMA article comparing ticagrelor plus aspirin versus ticagrelor alone versus aspirin alone. So I know even in the bypass surgery part, there are still controversial how long use the antiplatelet therapy, which choice would be best. Is my practical question. What is current guideline standard, and what is your preference? Is also this question would be many audition is wondering in Asian Pacific area. Could you comment on that?
That's a great question. So, as you know, dual antiplatelet therapy is not currently recommended after coronary artery bypass surgery, except for patients who undergo bypass surgery for an acute coronary syndrome and for a patient who undergo off-pump coronary artery bypass surgery. So the overwhelming majority of bypass surgery patients have received only aspirin after surgery. I think the Dr. Zhao trial was really important in providing the first signal that using ticagrelor with aspirin could improve graft patency, Dr. Park. But then, as you know, there have been other trials, the popular CABG trial from Europe, that have shown different results. And so that's why there is a little bit of controversy in the community. I cannot breach confidentiality, but I can give you a heads up that Dr. Zhao and me and others are working on that. And there is new data coming out very soon that will be incredibly important to address this question.
Hi, Professor Zhao. I just have one short question for you. So what is about the difference of insulin-dependent rate between the two groups? Is there any difference of the insulin-dependent rate between the two groups?
We don't have such data to compare the insulin using between two groups. But the DECABA trial, in DECABA trial, the rate of insulin dependent was identical in three groups: ticagrelor plus aspirin, ticagrelor alone, and aspirin alone. And the dual antiplatelet therapy had superior graft patency.
Okay, thank you.
Thank you, Dr. Wang.
Okay, comment? Okay.
Yeah, I also follow the question to Professor Zhao. And in China, for the post bypass, how to use the dual antiplatelet therapy, I mean the antiplatelet therapy, because ticagrelor or ticagrelor totally is available. And how much percentage of the DAPT for the post bypass in China, in your hospital, or in the whole nation for the post bypass?
Okay, in all hospital, off-pump CABG is carried out for almost 100% single CABG patients, and over 95% patients receive dual antiplatelet therapy. Only 5% with a high risk of bleeding receive aspirin alone. And then we also encourage our colleagues of Chinese cardiac surgeon to apply dual antiplatelet therapy, and the outcome seems better nowadays than 10 years ago.
Great, thank you.
Okay, thank you. So our time slightly delayed. So I'm gonna move to the last topic. Is I'm gonna introduce Professor Eun-Seok Shin from Ulsan Medical Center, Korea. She will talking about comparison of two different paclitaxel coated balloon in coronary in-stent restenosis. This is a random control trial. Okay, Professor Shin.
Thank you, Chairman. It's my great pleasure to present my topic, comparison of two different paclitaxel coated balloon in coronary in-stent restenosis. It's a randomized controlled trial. I have nothing to disclose. Recently, various drug-coated balloons are commercially available for coronary artery disease, and sirolimus and its derivatives has been investigated. However, the limus substance are basically the poorer transport rate compared with the paclitaxel. The genus paclitaxel coated balloon is a new drug-coated balloon with shellac plus vitamin E excipient. Sequent please is the reference device of this study, uses eopromide. The dose of paclitaxel was the same, 3 microgram per square millimeter. The purpose of this study was to evaluate the angiographic efficacy and the clinical safety and the effectiveness of the genus DCB in a randomized trial. It was registered on 7 domestic cardiovascular centers. Stable or unstable angina or silent myocardial ischemia patients more than 19 years old was enrolled. The inclusion criteria were lesion and Meran type 1 to 3 ISR with at least 50% diameter stenosis and over 90 days after coronary stent implantation. The exclusion criteria were acute myocardial infarction, thrombotic regions, and bypass graft region, and target vessel with complete occlusion and dual antiplatelet therapy was continued for 6 months. The primary endpoint was in-segment late lumen loss at 6 months. The secondary endpoint were major adverse cardiovascular events composed of cardiac death and target lesion myocardial infarction and stent thrombosis and clinical driven TLR at 6 months. And this is the result. And 82 patients with ISR were randomly assigned to genus DCB and sequent please. And 2 patients were excluded from each group because DES implantation after balloon angioplasty. So finally, 78 patients were included in the full analysis set. All patients had planned angiographic and clinical follow-up at 6 months. And the baseline characteristics were not different. It's quite similar. The age in the genus DCB was 67 years and the sequent please was 65 years, and mostly men and drug-eluting stent ISR patients. And this is angiographic and procedural characteristics. The mean syntax score was 9.6 and 8.9. At the end of the procedure, all patients had a TIMI flow 3 grade, and there were no procedural complications and bailout stenting. This is QCA data. Lesion length was 20 and 21 millimeter, and reference vessel diameter was 2.4 and 2.5 millimeter, and diameter stenosis was 62 and 65%. At post drug-coated balloon, minimal lumen diameter was 2.1 and 2.2 millimeter. The residual diameter stenosis was 20% and 19%. So acute lumen gain was 1.3 and 1.4 millimeter. At 6 months follow-up, minimal lumen diameter was 2.1 and 1.9 millimeter, and diameter stenosis was 23 and 30%. And late lumen loss in segment, the primary endpoint was 0.15 in genus DCB and 0.24 millimeter in sequent please. The binary stenosis was 6.5% only in the sequent please group. The primary endpoint 6 months late lumen loss was comparable in both groups. And this study demonstrated non-inferiority for in-segment late lumen loss. The one side 97.5% upper confidence limit of the difference was 0.13 millimeter, lower than the non-inferiority margin of 0.29 millimeter. So achieving non-inferiority, P for non-inferiority value was 0.001. This is a cumulative frequency distribution in segment Rayleigh lumen loss is quite comparable. And this is the cumulative frequency distribution of in-segment diameter stenosis after DCB treatment. The diameter stenosis and much decreased in both groups and maintained until 6 months follow-up. This is clinical follow-up that was completed in all 100% patients, and MACE composed of cardiac death and MI and stent thrombosis and TLR was 7.7 in genus DCB and 10.3% in sequent please group. There was no cardiac death. One target lesion myocardial infarction and one stent thrombosis were occurred in sequent please group. TLR was 5.1% in both groups. And this is the representative case. And these patients were ISR in RCA. 6 months after treatment, the results were quite good. So here are conclusions. The genus DCB is a new paclitaxel-coated balloon with Sherlock plus vitamin E excipient. In this multicenter head-to-head first-in-man randomized trial, the genus DCB was non-inferior to the reference sequent please for the primary endpoint of 6 months in segment Rayleigh lumen loss. This study provided the evidence for the efficacy and safety of the genus DCB treatment in treating coronary ISR lesions. However, long-term follow-up and large-scale study are needed to evaluate the clinical outcomes with the genus DCB in treating of coronary ISR lesion. Furthermore, this genus DCB should also be investigated in de novo regions. Thank you for your attention.
Okay, thank you, Professor Shin. So, and lastly, I would like to ask editorial short commentary from the Professor Yundai Chen and the PLA General Hospital in China. Okay, Professor Chen.
Okay, first of all, congratulate for the Professor Shen's team. A very wonderful and grateful the job. And as we know, until now, the in-stent restenosis problem also is worldwide and with a higher incidence. And for this kind of issue, JACC-coated balloon and JACC-eluting stent have quite a precise role in treating ISR. And how to select that, generally, also the ideal treatment remains debatable. So for this issue, I think to have two groups and give two devices provide the equivalent 6 months angiography treatment and primary endpoint for the late loss in segment rate late loss is quite palpable. So after this result, even not so large sample size, but also get a very nice result, can show us both safety and efficacy for the genus DCB. And also for this issue, Professor Shin just also mentioned maybe in the de novo lesion and also have some more clinical practice for this lesion. And I just want to comment until now for the DCB, it is also have a sirolimus DCB, right? So as already published some DCB focus about ISR or de novo, generally is head-to-head, is two device, generally is based paclitaxel JACC coating. Until now have no the sirolimus DCB compared to the paclitaxel DCB head-to-head in the in-stent stenosis or de novo. So I just want to initiate the question for the Professor Shin. Could you give some comments for the genus DCB? because you're quite familiar with this. Does it have any interesting finding for the de novo lesion? How many cases have you done for this genotype DCB, genos DCB? And also another question is, don't you have some comments how to evaluate the sirolimus DCB or paclitaxel DCB, especially for the instant restenosis?
Okay, thank you very much for your comment and questions. And I recently I used a Genos DCB for de novo regions. So but the evidence is not quite many. So it's just a start to study random the Genos DCB versus sequent please for de novo regions. So I just then several cases just follow the result is quite good, quite comparable. So I just then waiting the result. So and as you know, the JACC intervention is show the sirolimus DCB from B. Brown company,
Yeah.
and just then compared to the sequent please for ISR region. So as you know, in this study result, the late lumen loss is just statistically not different, but the numerically is more nice in paclitaxel DCB. Several times is more lower the value of the late lumen loss. And also, as you know, the paclitaxel is more rapidly, many rate to deliver the drug to the vessel compared to sirolimus DCB. So and also, and that is dependent to the excipient, but the excipient is quite similar in commercially available. So I think sirolimus is very difficult to deliver the drug to the vessel compared to paclitaxel. That is a drug nature.
Okay, thank you.
Okay, any comment or question from panel? Okay, so it's a propacine and the Genos DB, some different additive material is you mentioned vitamin E and the shellac. What is the main advantage compared to the chicken pre? Any underlying mechanism for that?
Yes, and it's quite a difficult question. So, and shellac is very common in some, so many companies just use the shellac as the excipient of the drug corridor balloon. But the companies mentioned about the vitamin E. I think they just and some put another component. I think and shellac plus vitamin E plus something, but that is a secret from the company. So I'm not sure. So they just only mention about the vitamin E. Vitamin E is some special to deliver the drug.
Okay, great. So I think time is already completed, and I hope the all audience really enjoyed this JACC Asia special session in TCTAP 2022. So, and the JACC Asia Journal is, I think, the one of the largest and the getting celebrity, the major article. We launched it 1 year ago, and we have published a lot of very nice review article also, as well as original article. And I hope all audience in Asia Pacific area, also in another world, including United States and EU, would you like to submit a very important paper to the JACC Asia? This is a very nice time to publish your very nice research, and we hope at the end of this year we got the impact factor more than 5. And I really appreciate all the panel and the moderator or editor-in-chief, the John Wang in JACC Asia, also Mario Gaudino, Professor Dong Zhao, and Professor Chen. I would like to close this wonderful session. Thank you for your all support. Thank you.
Thank you.
Thank
Great.
you.
Thank you.